Okay, so good evening to everybody. My name is Roberto. I am a member of the Prostate Cancer Support Toronto group. Before we start the evening, I have the really very sad duty to inform you of the recent passing of Gwen Tolhurst. Gwen was the chair of the Waterloo Wellington Prostate Cancer Canada Network Group from 2010 until his recent passing. Gwen was a very good friend of our organization, both as a long-term attendee of our group support meetings, as well as a facilitator in many of those meetings. He will be greatly missed. I would request that we spend just a few moments to reflect on his memory. Thank you. I welcome all of you to tonight's Awareness Night event, and particularly Dr. Maria Jiang, who will talk to us on the fast-changing landscape of metastatic cancer treatments. Dr. Maria Jiang is an assistant professor with the Department of Medicine at the University of Toronto, and also a medical oncologist at the Princess Margaret Cancer Centre. She's board certified in internal medicine and medical oncology in both Canada and the United States, with a Master of Science degree from the Harvard T.H. Chan School of Public Health. Dr. Jiang's main areas of interest are clinical trials and targeted therapeutic approaches in prostate and bladder cancers, and she has received multiple grant awards for her research. When she's not working, and it actually sounds like that does not happen very often, she's usually jogging in a park, or she's exploring a restaurant nearby, or watching a history documentary. For example, she mentioned the Roman Empire, or the rise of the Ottoman Empire on Netflix, or Rome or Chernobyl on HBO. Not necessarily documentaries, but they are apparently very, very good. Her hobbies include pasta, traveling, and movies with Al Pacino. I don't know if necessarily in that order. But again, I welcome Dr. Jiang, and now the evening is yours, Doctor.
Thank you so much. And yeah, not in that order at all, depending on the day. I just first and foremost would like to thank everyone for the opportunity and for inviting me. We have a great audience. I feel very popular tonight. And I'm very excited to offer you some of my perspective on metastatic prostate cancer. And it's so great to also see you guys, especially the ones that turned the camera on earlier, just to see you, how you're doing, how you're in your respective environment. So it's really wonderful. So without further ado, I'm just going to share my slides, and hopefully you guys can see. Let me just put it on presentation mode. There we go. Okay. So wonderful. So I'm going to start talking about metastatic prostate cancer, and it is it is an area with increasing complexity. We can probably talk about this for about a week, but I hope to at least give you some high-level overview of what's happening and what's up and coming in a fast-changing landscape. And I'm happy to answer your questions later on. So I have some disclosures. It's just regarding my previous engagements with industry in terms of consulting, speakers fees, and clinical trials and research. But the goal of tonight's talk is to really try to give a balanced discussion of treatment options in metastatic prostate cancer. There's a lot to go over, but I do want to give a bit of a roadmap on different aspects of metastatic prostate cancer care. I will first start off with some background in terms of prostate cancer and treatment landscape of systemic therapies. And I think a few of you have sort of asked about treatment sequencing, so I try to incorporate something on that. There's a lot of questions from patients these days about PSMA PET imaging, and I'm not a nuclear medicine doc and I'm not a radiologist, but I'll offer you some of my clinical perspectives on which situations might be the most useful for things like PSMA PET. We'll talk about some other aspects of management, which I think you guys should know, which often also cross other disciplines and different specialties. What's up and coming in terms of neurotherapies? I think a lot of you are wondering about that. And if we have some time, I would love to debunk some common questions and some common myths that I see and hear from the clinics. And then at the end, we'll get some of your feedback on which topics of information you would like to hear more about. So let's start with some background, and this is what I pulled from the most recent publication of Canadian Cancer Statistics, projected numbers from 2022. I'm not a really numbers person, but I think it's good to have some perspectives. In 2022, it is estimated that 24,000 patients will be diagnosed with prostate cancer, and we'll have 4,600 deaths attributed to prostate cancer. And as we all know, prostate cancer is a really common cancer and is certainly the most commonly diagnosed cancer among Canadian men. And overall, it is about 4th on the list for the most commonly diagnosed among Canadians. It is also the 3rd leading cause of cancer death, and 1 in 9 men will be diagnosed with prostate cancer in their lifetime. So we all know, we all have each other, we all know somebody with prostate cancer. So it is certainly a big community of patients who are affected by this disease. And the second thing I would highlight in terms of epidemiology is that there is a geographic variation in prostate cancer in terms of incidence and mortality. We're very fortunate. We live in a country with relatively good access to diagnostics and treatments, et cetera. So we tend to have a higher incidence, but a lower mortality in some of the other countries in the world. But even within Canada, there is increasing recognition. There's racial disparities that happens in the outcomes of prostate cancer, and I'm sure that there's contributing factors, including biology, access to treatment, and and other factors. Response to treatment, perhaps. But just so we're aware that there is a lot of people who are in need of prostate cancer treatment who may not be able to get them in other parts of the world. So in terms of how many patients are affected with metastatic prostate cancer, fortunately, it's not a big a majority piece of the pie. Most of the patients are diagnosed with localized disease, and a lot of them will be cured of their prostate cancer. But unfortunately, some people do end up relapsing and developing metastatic disease. About 5 to 10% of patients will end up develop metastatic disease upon diagnosis. So, and these patients tend to have more aggressive natures of their disease. And have suboptimal outcomes. So we need to really work on these patients to try to improve, their chances of having a good outcome. I think one of the things certainly can be confusing to patients and to some of our trainees also is sort of the disease states and some of the terminologies we use in metastatic prostate cancer. And there's so much information out there. And sometimes it's difficult to have a good discussion without really understanding which disease state we're talking about, because prognosis and treatment can be quite different. So I'll highlight a couple of things, even though I'm talking about metastatic prostate cancer today, but there's different variations of metastatic prostate cancer. On the left, I think it's pretty self-explanatory. You'll see that there is localized disease, and localized prostate cancer will have local treatment. Some of the patients will develop recurrence, unfortunately. And if the recurrence turns out to be metastatic disease, and they have metastatic disease without being on hormone therapy like ADT, then they have what we call metastatic castrate-sensitive prostate cancer or hormone-sensitive prostate cancer. So you'll see things like MCSPC, MHSPC. So these are guys who have metastatic disease, but they're not castrate because they're not on androgen deprivation therapy. And you'll also have a group of patients who initially get diagnosed with metastatic disease. So these are called de novo or synchronous MCSPC. And of course, upon diagnosis, they're not on ADT, so that's what they have. We don't unfortunately have curative treatment for most of these patients. So they will have their disease controlled for a number of, years, hopefully. And then patients will sort of develop castrate-resistant prostate cancer or hormone-resistant prostate cancer, which just basically means that when you're progressing already on hormone therapy with a low testosterone. Okay, so I think it will just hopefully be all on the same page about those kind of things. So it's kind of important to frame in your mind. So how do we decide about management strategies? Well, just in big category terms, we have local therapy. We often think about this for localized disease, so things like prostate surgery or radiation. Systemic therapy, which is what I give as a medical oncologist, I give drug therapy to hopefully address cancer not only in the prostate, but cancer that has spread from the prostate. So it's more systemic. So it's given for systemic disease. Now, sometimes we'll actually use a combination of both, and I'll touch upon some of the scenarios to think about that strategy in a bit. And sometimes if it's a really, really indolent cancer and it's, not causing the patient any harm, to just wait a little bit and survey them. Sometimes we'll actually, avoid the toxicity of treatment just by close surveillance. And so we don't tend to give them, drug therapy if they don't need it. So that's another strategy we sometimes adopt in selected patients. And what we decide to use really depends on what is the goal of the treatment. Are we trying to cure the patient? Are we trying to prolong the disease course for the patient if we're not able to cure them? And can we improve or preserve their quality of life? And I'll mention the quality of life. I think the concept is sometimes tricky to understand because, how do we have quality of life as a cancer patient with an incurable illness, right? And I think it really depends on a lot of things. But one of the things I'm really, I really have to consider is what's contributing to a negative quality of life. And if that's the disease, for example, if a patient is coming in really extensive cancer burden, a lot of symptoms from the cancer, and that's a reason for the negative impact on quality of life, well, that patient may need to have some treatment, including chemotherapy sometimes, to really hold the cancer back, to give that energy back to the patient a little bit. And in that case, we can actually use treatment to improve quality of life. If the patient is really not that symptomatic, then how do we use our existing treatment options to preserve that as long as possible? And that's also another important question. So in terms of systemic therapy, this is a complicated figure. I'm not going to go over in detail, but just sort of, really big basic categories. Prostate cancer, as you guys probably know, that is mainly an androgen-driven disease, at least at the beginning. So it responds to androgen suppression. And at least initially, it is responding to that because it's androgen-dependent cancer. So we often start you on hormone therapy, and we can control the disease for a period of time. And then, of course, the prostate cancer gets really smart. And so part of it can still be androgen dependent, but then it starts to develop androgen independent mechanisms of resistance. So then it doesn't completely rely on the androgen pathways for its growth and then starts to progress. So depending on which stage you're at and what treatments you've had in the past, then we can sort of think about what treatment options are available to you. Typically earlier on in the metastatic prostate cancer setting.
We forgot about this meeting.
So, earlier on in the disease trajectory, we'll tend to use hormone therapy for androgen dependent disease. And as they progress upon hormone therapy, then we use more things like chemotherapy and other targeted agents to address those mechanisms of resistance. We typically would continue the patient on ADT, and we always think about clinical trials, which we'll touch on in a little bit as well. So with that framework in mind, I would like to go over metastatic castrate-sensitive prostate cancer and then castrate-resistant prostate cancer. So let's start with MCSPC, as this area is changing very quickly. So essentially, ADT was used since 1941 to about 2014. And, during the 70 years of its use, patients with MCSPC just used ADT alone and then was waiting for the cancer to progress to MCRPC. Now, just in the last 7 years or so, we've seen a smattering of different drugs being approved in this space, and all of them have shown incredible results and improvement in overall survival for patients. So now we have this envious problem having so many different options, and how do we really best utilize them? How do we best combine them in some patients as well? How do we best select our treatment? Well, let's take a look at what we have. So the first practice-changing study was called a trial called the CHARTED trial, and that was published first in 2015, and this was using docetaxel chemotherapy. So basically, the investigators were, hypothesizing that, well, since ADT alone may not be the best, can we add additional chemotherapy to see if we can improve overall survival of the patient? So what they did was they randomized the patients as a big global study, but half the patients received ADT plus chemotherapy, docetaxel for 6 cycles, so that's 18 weeks of treatment, and half the patients got ADT alone. What they found was in patients with what we call high volume disease, and the definition is here, but essentially it's patients with more than four or more bone metastases on conventional imaging, or if they have liver or lung metastasis, what we call visceral disease. And these patients often are very high risk. And these are the patients that really benefited from this combination treatment approach. And you see the median overall survival, which is just, you can think of it as an average sort of effect. Average overall survival of patients who got the combination was almost 50 months, whereas the ADT alone patients, their survival was 32 months. So that's a difference of a year and a half, maybe 17 months, which is huge in the oncology world. This was a plenary presentation at ASCO that year, and we've really rarely seen improvement over survival of that magnitude. But what was also interesting was that docetaxel only benefited patients with high volume disease, and in patients with a limited volume disease, so maybe a couple of bone mets or just lymph node disease not involving the bone, then it didn't really do a whole lot for the patients to go through chemotherapy. Then we had more studies coming out in 2017, and the first was the Latitude trial. And this was looking at the combination of Zytiga or abiraterone, and this was continued until progression. So patients could be on this for like a year and a half, 2 years, 3 years, or whatever it took to them to MCRPC. And so they were combining this combination versus ADT alone. And what they also saw was this, similar overall survival benefit that's kind of similar to what we saw with CHARTED, which was interesting. So without head-to-head comparisons of chemotherapy and abiraterone, there was a big debate among the prostate cancer community about which is better to use. And I think a lot of people went with abiraterone, including myself, because it's a safer option for patients. And if the benefit seems to be similar, then I think that minimizing toxicity is important for us. And then since then, we've had a bunch of trials, all level 1 evidence phase 3 trials, looking at another trial, abiraterone, apalutamide, enzalutamide. And these trials really cemented novel hormonal agents in this setting, not only for high volume disease, but also patients for other types of MCSPC, so low volume disease, whether you had recurrent disease or newly diagnosed de novo disease. It seems that every type of MCSPC patient could benefit from these treatments. So that was a really game changer. And then around 2018, we also had a STAMPEDE trial, which looked at the addition of radiation therapy to the prostate. And this was interesting because this is one of the only cancer disease sites that I know of that sort of looked at this approach and was a positive study. But essentially, the idea is that if the prostate cancer originating from the prostate was only spreading to a few sites, not a whole lot, and that was the area where the cancer cells was disseminating from, then perhaps we could just, do the radiation to that site and have additional benefit in, preventing further dissemination. And what they saw was an improvement in overall survival at 3 years from 73% to 81%. Now, that might not seem like a whole lot, but when you're looking at the relative risk reduction of death, it was almost the same as what we saw with abiraterone. So it's almost like we're getting the same benefit from radiation to the primary than taking a drug for a very long time, which is quite thought-provoking. But this trial really put radiation to the primary at the forefront in patients with newly diagnosed low volume disease. So then, we had a number of years where we were trying to adopt these newer treatment strategies. And then since ESMO 2021, and then earlier this year, we've also had data for what we call triplet therapy for the highest risk of patients newly diagnosed high volume MCSPC. Now, the triplet therapy was combining ADT plus docetaxel plus a novel hormonal agent, so all three together, versus the standard of care at that particular time when the study was designed, ADT plus docetaxel. So you'll see that the triplet was not combined, or was not compared to ADT plus a pill, which is what most of us commonly use now. But this was really important for a couple of things. Number one is that we saw a really significant improvement in median overall survival from a couple of studies, Peace-1 and Arisons, and these are phase 3 studies. And the improvement is, again, very, very impressive, 1.6 years. Arisons didn't report we don't have the median overall survival data yet. It's not yet reached, but the magnitude of benefit seems to be very similar. So that's a significant number. And we also see for the first time these patients are living beyond 5 years from these studies, which is also very encouraging. And then we recently had at ASCO conference that we saw the ENZAMET study, which is not a completely definitive, I would say, randomized trial to answer this triplet question, but they did have a subgroup of docetaxel treated patients in this cohort of patients that had this de novo high volume disease. And again, it's not randomized, so you don't really know exactly, how to maybe interpret the data. But I would say that, if you look at the curves of the triplet versus, ADT plus docetaxel versus ADT plus Enza, most of it looks fairly similar, but there was a bump in that circle where the gray line with the triplet therapy seems to be performing better than the rest. So, I think most people would interpret this as not all patients need the triplet therapy, but some patients with really aggressive disease for that first year or two, we could potentially really improve their outcomes by giving them the triplet. So that really leads us to the question of who do we give triplets to? Which patients may need triplet therapy? I gave this talk at the our Canadian GU meeting at Charlottetown in June. And I think that we need to really think about these patients in the setting where they have, first of all, de novo high volume disease, and secondly, if they have very aggressive disease biology, for example, they have liver metastasis. And liver metastasis in the abiraterone trial didn't actually seem to show a benefit with just using ADT and abiraterone compared to ADT alone. So that really suggests to me we need something else for these patients. The other sort of group of patients I think about is patients who may not have a good PSA response to one of these hormone pills, right? And the reason is all of these trials that looked at PSA response suggest that if your PSA response is not great, then it's almost like you're getting ADT alone, like your outcomes are actually quite poor. The trick is that we don't really know who's going to have a good PSA response up front. So, how do we sort of navigate that? Well, one of the things we think about is how much PSA production is the cancer doing? So we see a lot of disease, extensive amount of disease, and your PSA is like 10, right? And that might suggest that your cancer is not really relying on a lot of antigen-dependent mechanisms to produce PSA. So potentially these patients will not have a long-lasting duration or response with just a hormone pill, and perhaps chemotherapy is needed to further improve the outcome of these patients. So, and the field is also really moving towards treatment intensification for other cohorts of patients. So there's ongoing trials at Princess Margaret and also at, at other centers as well. Some of them really looking at targeted therapy if you have any mutations in your cancer that's amenable for target approaches. And I often speak to my patients about some of these trials to be screened and see if they meet these criteria. And there is a lutetium study in MCSPC, which is not, I don't believe it's available in Canada, but it's in the US. And then, some other approaches are looking at radiation to certain metastases. But, there's this sort of trend of increasing the amount of treatments at this earlier setting, especially in patients with higher risk disease, to see if we can improve their overall survival. So while all of that is going on with systemic therapy, there's also some provocating data on local therapy. So we can potentially maybe think about utilizing some local therapy for metastatic disease if the metastatic disease is not extensive. So most commonly we think about radiation to what we call oligometastatic disease. So if you have, 2 or 3 bone mets or a few lymph nodes, perhaps giving you a drug for many, many years is a bit of an overkill. Or perhaps we can take the drug and also do the radiation together and see if we can keep your disease control for a lot longer. And there are 2 small studies that looked at this strategy. They were not done with really ADT and the ABI and the NSAIDs because it was not available at that time. But they basically showed there's benefit if we can radiate these lesions that can delay the initiation of ADT and that can delay essentially disease progression. Now, the big question will be, right, whether this approach is going to be better than, taking the drug therapies. Or should we combine them all together? And so I think that question still remains to be answered, is how do we fit this approach in our current systemic therapy treatment algorithm? So, like I mentioned before, we used to have ADT alone for all patients with MCSPC before 2014, but now it is a much more complicated discussion with our patients in clinic. And depending on which group you're in, the treatments that we're discussing with you might be a bit different. But overall, we can say that ADT alone is no longer the recommendation for the vast majority of patients, unless you are, extremely frail that you can't even take things like abiraterone and enzalutamide. So we are going to talk about additional treatments with you to prolong that disease control in this setting. So that's all great that we have all of these treatment options. What is happening in the real world? And the real world is actually very disappointing, unfortunately. So this is showing some examples, and this is from Ontario, but we have similar data in BC, in the US, and the UK as well, in Europe in general, that the adoption of treatment, so-called treatment intensification using ADT plus a systemic therapy, the uptake of this is actually extremely low. So this is after these trials have all been reported and have all been incorporating guideline recommendations, but we see that the proportion of patients who are taking ADT plus abiraterone, for example, is only like less than 5%. We see people using docetaxel, that's about 10%. And in the US, and so just actually taken recently, that those percentages are about 20% or so, maybe at best. And most of the patients are still getting ADT alone, which is such a shame because we have such good therapies for these patients that can significantly improve their overall survival. But for whatever reason, we still have a long way to go to actually make sure our patients are getting these treatments, and research is ongoing to address what are the barriers for this. So moving on, let's talk about castrate-resistant prostate cancer. There's, again, a lot of treatment options that we have. And I think some of this may have been addressed already by the previous talk that you guys had with Dr. Emenegger in 2021. So I'll maybe focus a little bit more on the two newer treatment options, just to sort of, because of time limitations. But I want to highlight one thing from this slide is that, compared to what you saw with MCSPC, when the overall survival improvement is about 1.5 years or more, The mCRPC treatments that we have in this setting only improve overall survival by about 3 or 4 months for the vast majority of these agents, which is, much less. But, I do believe that if we're able to maximize your lines of therapy and expose you to as many treatment options as we can significantly improve overall survival. But it is a much more limited benefit with each line of therapy. And so I think that it's something that's quite different about these patients. And so with all of these treatments, how do we select the treatments? I think that, in my mind, we really have to look at the patient individually. I really don't believe in treating every prostate cancer patient the same. And that really involves, talking to the patient, looking over the files and getting a sense of the disease, getting a sense of what's the patient going through, what have they tried so far, and what's available to us, right? And in terms of, these things, what I look at mainly 3 things. I look at what is the symptom burden, what is the extent of the disease and the changes on imaging, and what is, the trajectory of the PSA. And each one of them may not be, very reliable on its own, maybe except for clinical symptoms. But all taken together, that really gives me a good picture of what's going on. But for example, PSA alone will not tell the whole story. Okay. And from a patient perspective, what is the sort of fitness level of the patient? Can they tolerate these types of treatment? What are their comorbidities? I mean, if they just had a cardiac event 6 months ago, perhaps something that could further damage the heart may not be the best option, right? And so you really have to figure out in this complicated sort of system, what is the best for that particular patient at that particular time. When we look at Ontario, this Ontario data is very similar elsewhere. We see that a lot of patients can get the first line therapies like abiraterone and enzalutamide. But beyond that, in second line, third line settings, very few patients are able to get on these treatments, and a lot of people unfortunately drop off. So I think we still have a lot of work to do in this setting as well to really try to maximize the line of therapy for our patients. So let's move on and talk about some of these newer therapies. And I think one of the hottest things that's currently in the field is lutetium. And this is falling under the category of radioligand therapy or theranostics. Theranostic is basically combining therapeutics and diagnostics. And in the case of lutetium PSMA, so it's combining PSMA, which can be detected on PSMA PET, and then combining that with a linker that's attached to a beta radiation particle, and the whole thing binds to PSMA expressed on tumor cells, and it gets internalized and releases the radiation inside the cell and achieving cell kill. So it's almost like a smart bomb, if you will, which is a very attractive way of killing the cancer cells and hopefully sparing some of the normal cells from toxicity. The therapy study was a phase 2 study, I think was really informative. And this was an Australian study that looked at lutetium, comparing that with cabazitaxel chemotherapy. And cabazitaxel is the chemo that we use for patients who progress on docetaxel. And this trial used a very strict selection criteria. They have to have a high PSMA uptake on their scan, on the PSMA PET scan. And they all had a second FDG PET scan. So they can't have an FDG positive and PSMA negative scan. So it's a much more restricting sort of set of eligibility criteria. So they selected these patients and then they randomized these patients to receive either treatment. And what they found was that the lutetium had a higher PSA response, so 66% versus 37%. Patients also had longer progression-free survival. But when we look at overall survival, which was reported earlier this year, there was actually no difference when it compared to chemotherapy. And I think a lot of us were quite disappointed to see that. The silver lining, I guess, is that even though the overall survival is similar, the side effects of lutetium is much easier than cabazitaxel. So, where you are able to achieve that overall survival benefit, perhaps without the toxicity of cabazitaxel, but there was certainly no advantage over cabazitaxel based on this phase 2 trial. The only phase 3 trial we have for lutetium as of today is the VISION study. And the VISION study was a US study, and it used a less restrictive eligibility criteria for screening patients based on their PSMA PET. How they defined PSMA PET positivity was a bit different. And as a result, most of these patients were deemed to be positive, and 87% of patients went on the study. These patients were heavily pretreated. About 45% of patients had already 2 lines of chemotherapy. So there were not a lot of options left for these patients. And the study design was kind of interesting. They were doing this sort of combination of lutetium with the standard of care versus standard of care alone, but the standard of care did not include any life prolonging therapies. So it's not like therapy where you actually was comparing to an agent that improved overall survival. It was just comparing to things like palliative radiation steroids or an alternative novel hormonal agent, which, as you'll see later, is not the most effective approach. But this study looked at lutetium in this sort of space and turned out to be a positive study, and which led to FDA approval. PSA response was 46% versus 7%. There was improvement in progression-free survival and overall survival. It is currently awaiting Health Canada approval. We're expecting something maybe late this year. But I will say that there is also a lot of hurdles I think we have to jump through in order to make this accessible for all of our patients in Canada and also in many other countries. And the reason is that, number one, PSMA PET is not routinely available yet for patients. And number two, our nuclear medicine department, which is the department that actually administered these drugs, were not designed to fit patients over there, because they were, built many years ago, and they typically don't even have nurses there, right? Like it used to be an imaging facility, or they don't have any nurses. They usually, they usually have very limited monitoring equipment and very limited spacing to accommodate all of these patients. And we're lucky enough that we have a very experienced nuclear medicine program at Princess Margaret. But you can imagine in some of the community centers, when you have a treatment like this that requires nuclear medicine, that can be very difficult to adopt. So I think, it's going to take a while for us to really figure out some of the logistics. And it's certainly much harder to do something like this rather than just give abiraterone or just giving chemotherapy at Princess Margaret's chemotherapy center. So something to keep in mind, certainly for all of us. And the second sort of new area I think is generating a lot of heat is targeted therapies or PARP inhibitors. And this is a bit late to the game for prostate cancer, and PARP inhibitors have been used in other cancers like ovarian cancer and breast cancer and probably other places as well. But PARP inhibitors essentially work on tumor cells that have homologous recombination deficiency, or we say HRD mutations. They have this deficient mechanism of repairing broken DNA. And when you give the PARP inhibitors to these tumor cells, it further damages the tumor cells' repairability, so they basically die. But in normal cells, they have another pathway that they could repair DNA with, so they survive. So that's really the gist of how they work. And PARP inhibitors have come to prostate cancer because some prostate cancer tumors express these mutations or have these functional mutations. And that's about 25% of the patients. These cancers tend to be quite aggressive, so we need to treat these patients probably a little bit differently by using more of a targeted approach if that's available. And what's really changed the game was the PROfound study that was reported in 2020, where patients were randomized to receive olaparib versus an alternative novel hormonal agent. And you can see the response rate for PSA is 43% versus 8%. There's improvement in PFS, there's improvement in overall survival. So, across the board was a positive study. But when you look at this PROfound study, I think what's interesting is that not all mutations are the same. So there's a couple of mutations that may be driving the benefit, mainly is with BRCA2 mutations, where you see the blue bar, which is the olaparib, and the control arm was the red bar. And so the longer it is, the more benefit there is with PFS and OS. And you can see some of the other mutations, the two color bars are fairly similar, right? So there's not a whole lot of difference. But the challenge is that some of these tumor mutations are very, very rare. And so it's hard to draw conclusions. But overall, not all mutations are the same. I think BRCA2 benefits the most. In Canada, Health Canada approval is for the cohort A of this trial, which included the BRCA2 mutation. So that's BRCA1, 2, or ATM. In Europe, it's only BRCA1 and 2, and in US, it's like all of them. So there's a bit difference in how different agencies interpret it. But I think the most benefit is with BRCA2, maybe BRCA1. And the other sort of aspect of this that is really hit the prostate cancer community is that how do we test for these mutations? And one of the things is that medical oncologists like myself, we were not trained to be knowledgeable when it comes to mutations to enough degree that we can advise on patients about what this means, what these changes mean in a lot of these settings. So, a lot of us had to learn about these mutations and how we test what they mean and all this kind of thing. But I think the two main things that is really take away from this is that a mutation can be hereditary or germline or somatic, i.e. acquired. And the difference is that in germline mutation is you are born with mutation. One copy of your DNA is affected, you got it from one of your parents. And then as time goes on, the tumor acquires a second mutation in the other DNA. So then you get this prostate cancer. At least that's what we think happens, okay? And the implication is that you can pass down this mutation to your, to other family members. So for example, your siblings might be affected because your parents had it, one of your parents had it, or you can pass it down to your children. And because these cancers tend to be very aggressive, it's important to screen the affected family members for earlier cancer detection so that they can have better outcomes. Now, for a tissue somatic acquired mutation, it's different because you're born with normal DNA when it comes to HRD. And then at some point, the tumor acquires one hit, and then later on gets a second hit. So the difference is that the mutation is only in the tumor, okay? And when you test for the non-tumor cells, like in the blood, like your white blood cells, or maybe your skin, or maybe your saliva, you don't see the mutation outside of tumor cells, which is different than the germline mutation, okay? So it is important that we understand these differences, and this is now available in Ontario, and I believe I'm sure in BC as well. So all metastatic prostate cancer patients are eligible for germline testing, and every metastatic prostate cancer patient is eligible for somatic testing. And that is because of the PROfound study giving us the option of olaparib in these patients. Now, we mentioned this earlier, but in terms of treatment sequencing, back-to-back novel hormonal agent, we now know has very limited efficacy. So we've had multiple studies now showing that if you go from Enza to Abi or Abi to Enza, in vast majority of cases, even if you have a response, the response is quite limited. So that's not the best approach if you have another option. But when we look at all these studies, if we switch a mechanism of action, we see a much better treatment outcome. So if you have another option, I would say go with switching it to a new mechanism of action that cancer hasn't seen before, and that's better than back-to-back novel hormonal agent therapy. The second lesson about treatment sequencing is that we now know that moving some of the treatments earlier in the disease setting gets more bang for our buck. The best example is when we talked about MCSPC, the docetaxel, the abiraterone, these agents we used to use for MCRPC, but by moving them earlier in the disease, we're now seeing benefit of 1.5 years, right, versus 3 or 4 months. We also see some potential data suggesting if we use olaparib early, we can also get some good response. So for example, in the PROfound study we just talked about, patients who went to the control arm, 2/3 of them actually crossed over or received olaparib when they progressed again. But those patients never caught up because they still had an inferior overall survival to patients who got olaparib at the beginning of the study. So if I have a patient with a mutation, especially BRCA2, I would tend to use that approach rather than chemotherapy if I can, right? Now, if a patient is progressing really, really rapidly, that I may need to pull out chemotherapy. But in those kind of scenarios where I can use olaparib earlier, I'll usually try that earlier. We also saw some previous data when we used radium-223, which is an alpha emitter radiotherapy. It seems that the benefit was a little bit more in patients pre-chemotherapy. And you wonder if that same will apply to lutetium as well, as we sort of test the drug earlier in the disease. So we currently have the SPLASH trial for patients who are pre-chemotherapy, and we're actually the top accruer on for the global phase 3 SPLASH study. So we're seeing really exciting results. And part of me thinking is that perhaps we are going to see a bigger benefit compared to what we saw in VISION, because these patients haven't seen chemotherapy and they may have less resistant prostate cancer. Okay, a couple of words on PSMA PET imaging. This has really taken the field by storm. What we used to do is rely on anatomic imaging, CTs, MRIs, or radionuclide bone scan. So these kind of imagings really look at size criteria, and we're counting, how many lesions are there. If it's a certain size, then it shouldn't be there, then that's abnormal. So it's only looking at size and structure. But with a new molecular novel imaging, we're also able to get molecular information. Is there expression of PSMA on the tumor cells? And it can also be fused with CT or MRI. And the idea is that even if it doesn't meet size criteria and the disease is there, but it's too small to be detected on CT, it can still light up on PSMA PET where we can see them. So there's a much higher detection rate than conventional imaging. And the other advantage is that you get all of your information on one scan, right? And a lot of you will know that CT and nuclear medicine department are two different departments. So it's hard to get your CT and bone scan sometimes on the same day. And it requires multiple trips and calling multiple departments to report your scans. Or if you just get a PSMA PET, you're good. You don't need to come back for a different scan. So that's really nice to have. But like everything else, it's not perfect. And we're still learning on how to really read PSMA PET, how to incorporate PSMA PET, and when to order it. Does every patient need a PSMA PET? How can it help select our treatment? And really, does it improve outcomes for our patients? And that's really the biggest question, I think, for this. Now, we know that the detection rate is higher, even if your PSA is fairly low, where we miss a lot of disease on CT and MRI and bone scan. PSMA usually will pick up more disease. So even if your PSA is 0.5, there is a 50% chance it'll pick up something that your CT and your bone scan won't pick up. So it's very sensitive. However, there are situations where you can get a false positive, okay? And there are some radiologists who are very familiar with PSMA PET who can distinguish that. But if you're getting a radiologist who's less familiar with how to read these things, it might be a challenging case. And the clinicians are also, clinicians like myself, we're not trained to, of course, look at imaging. So we really have to put our minds together to figure out, is this something that's real that we're seeing? We also know in the mCRPC setting, there's some tumors that are PSMA negative. And this is why the VISION study and the therapy study all had to make patients go through a PSMA PET to screen out these negative tumors, right? And in fact, these PSMA negative tumors actually are very aggressive tumors, and they actually do fairly worse, and they often need chemotherapy. So having a negative PSMA PET also does not mean we're out of the woods either. So, I put some scenarios, some example scenarios for utility of PSMA PET, just to get a flavor of, what we're kind of thinking of how to best incorporate this novel imaging. Again, I have to say, I'm not a nuclear medicine specialist, and this has to be discussed in a multidisciplinary setting. But just to kind of give you some feelers out there of, what we're thinking. So for localized prostate cancer, I think, a lot of patients with, intermediate risk disease that's a bit more high risk or high risk disease, there's some benefit of getting these patients a PSMA PET. Because if your CT and bone scan are negative and your PSMA PET is detecting metastatic disease, you can potentially avoid things like a big surgery if it's not going to help you cure the disease, right? And then you can institute systemic therapy earlier, and get more treatment options started earlier. So so I think that's a potential benefit, even though you probably don't want to know you have metastatic disease. It's probably the surgery is not going to get you further ahead in that type of setting. But let's say if you have a localized prostate cancer and you're very low risk, right? You're like one of those patients that just require active surveillance, and then you do a PSMA PET because your conventional is negative, and you get a false positive. Then you assume you have metastatic disease. Now that's really terrible, because then you have to think about systemic therapy, of the treatment side effects for drugs that I give, and that actually gives you potential harm. Okay. In the setting of biochemical recurrence, is a similar sort of thought and process. Let's say if you had a surgery for your prostate and your PSA is going up, you're thinking of salvage radiation, right? And you're picking up PSMA PET metastatic disease, then you might say, well, radiation to the prostate is not going to help with dealing with the metastatic disease, and we should really move on to systemic therapy. And if we can do that earlier, that's a potential benefit. But if you're getting a false positive, then you actually avoid curative intent salvage radiation therapy to the prostate. Then it's a big problem, right? Then you can potentially undertreat the patient. So, but if you have a PSMA PET that localizes the disease in the prostate, and then you treat that with salvage radiation, you can have very good outcomes. I have a patient who's been through that scenario for a couple of years, and his PSA is very, very low. So, that can actually help. Now, what about in the metastatic setting? So in the metastatic setting, I think it's a little bit different, because we're not talking about curative versus palliative. We're mainly talking about palliative or incurable sort of condition. So, but there's still potential scenarios where you may miss out on certain treatments. So we talked about the role of radiation to the primary and low volume disease. Well, if you get a PSMA PET, which shows high volume disease, do we still radiate to the primary? And if you don't, are we going to miss out on the benefit of potentially radiating to the primary and obliterating the original tumor? Potentially, that could be undertreating the patient, okay? And if you have a false positive, then you're going to start on earlier systemic therapy, wrongfully assuming that you have more extensive disease, and you may miss out on some of the, for example, metastasis-directed therapy that we talked about. If you have mCRPC, now we need to have, let's say if lutetium is available as standard of care later on, you do need to have the PSMA PET scan to screen for eligibility. So that's definitely a plus, that it opens up another treatment option potentially. But if it is a false positive, then it can also make the patient waste more time on a treatment that may not necessarily help them. So that's also something that we need to really figure out. I think, most of the time, I think PSMA PET at our center, I might be biased, is pretty good, but I do think false positives are out there, and we have to be mindful about that. So I'm going to talk about the next section fairly quickly, but just to think about some of the wellness aspects of our patients, it's really important to think about bone health because of our treatments, the risk for osteoporosis on ADT and hormone therapy. And also in the mCRPC setting, you have a risk for more skeletal-related events like pathologic fractures and such. So everybody should be on calcium and vitamin D and should get exercise when they're on ADT. And if you're having mCRPC with bone metastasis, you should have additional bone-targeted agents to protect your bones. But unfortunately, it remains underutilized. Cardiovascular health is also important. We know that cardiovascular mortality is the leading cause of death in patients with prostate cancer. And that's, very surprising to a lot of us. And even if you have metastatic prostate cancer, a lot of patients actually die of their cardiovascular disease rather than their prostate cancer. So we really need to think about how do we decrease the risk of these patients. So making sure the risk factors are under control. And again, exercise is very important. How do we do exercise? There's actually some information out there and suggesting that it can actually reverse ADT associated muscle loss. And I think a lot of people on ADT will attest to that as a very common side effect of ADT. And there is information out there. I took a screenshot of this particular exercise video on YouTube that you can maybe refer to, but combination resistance and aerobic exercise training program can be really helpful. Mental and cognitive health, and I think this is underreported. You know, I think that the prostate cancer, you know, is a disease of, you know, patients who are older, and also there is a lot of testosterone receptors in the brain. And when you're changing those dynamics, you can have a lot of cognitive issues. And we also see a lot of depression in prostate cancer patients that likely is underreported, right? So I think we really need to think about this, and not only to, you know, help the patients, but we also know that patients with depression patients with prostate cancer have depression, have worse outcomes of their prostate cancer treatment outcomes. So it really, the mental health, it really affects much more wider net of things than we think. And, you know, if you're struggling with something like this, it's really important to get help early and speak up, because it is really important. At our center, we do have psychosocial team who's very experienced. We have a geriatrics team who's very experienced. And I'm sure at BC or other places have similar sort of support networks. And it's very important that we take advantage of these. What are some of the newer upcoming therapeutic strategies underway? Well, there is a lot of trials coming. A lot of them testing combination strategies and all types of combinations you can even imagine with hormone therapy, immune therapy, PARP therapy, PSMA targeted therapy, and other targeted TKIs. And so there's a lot of things out there in various disease sites. There's newer radioligand therapies coming up, CAR T cell, bispecific antibodies, antibody drug conjugates. They're all in the works. So a lot of things coming, but these are still early being tested in clinical trials. I put up this slide just to summarize what we have available at Princess Margaret in terms of clinical trials in the metastatic space. And this is after, you know, getting multidisciplinary input from the radiation oncologist, from the urologist. So there's a lot of activity going on, and we always encourage patients to think about clinical trials as they give us really newer options to treat the cancer, perhaps better than what we've been doing before. I'll have a special shout out to the PR21 study at the bottom, which is not open in Ontario, but in BC, they're testing lutetium against docetaxel in the MCRPC setting. So, you know, if you know somebody who might be interested in that, you know, that trial is open in BC, hopefully in Ontario soon. Okay, and then lastly, you know, I would just maybe talk about some of the common questions I often hear about in my clinic. And maybe these are questions that you had in mind or didn't want to ask, or you knew somebody who had these questions, but, you know, hopefully this gives you some framework to think about. One of the things I hear more commonly is that somebody says to me that I would never consider chemotherapy because somebody they knew with a different type of cancer had it and it made them really sick. And I think that one is that a lot of different cancers use different types of chemotherapy. Prostate cancer chemotherapy is not really a highly toxic regimen, it's a single agent. And I think that most of the patients that we see, you know, if they are getting to the point where they're really ill, we actually can, you know, have strategies of dose reduction, having more supportive care therapy. So a lot of my patients actually go through chemotherapy with some side effects, but they're quite manageable. The second is that, you know, I'm on chemotherapy, I don't feel any side effects, so it's not working, which is also not true. If you don't have any side effects, it doesn't mean it's not working. It's probably a good thing because you don't have any symptoms of cancer probably, and so I'd like to hear that. PSA is having a minimal increase, any treatment ASAP. This is also a myth because if let's say your cancer is quite indolent, you probably don't need the toxicities from the treatment as yet, but we usually keep these patients on close watch. Getting a biopsy will make my cancer spread. This is also not true. There are very exceptional cases like in adrenal cancers, primary adrenal cancers or in testicular cancer. We typically do not get a biopsy, but getting a biopsy for your prostate cancer is very important. It provides us a lot of information. So I actually get biopsies for my patients quite a lot. It helps me with molecular profiling. It helps me to rule out other aggressive variants like neuroendocrine cancers. So do not think that getting a biopsy will make you worse. It actually will help us to tailor your treatment. Pain medications. Patients worry that they'll get addicted. And the truth is that you will get addicted. Maybe you will get addicted to pain medication if you're taking pain medications when you have no pain, right? But if you have pain and you're taking pain medications to make it easier, you're not going to get addicted, and it helps you to feel better. It helps you to take treatment better. It helps you to eat better. It helps you to sleep better. So if you're in pain, a significant amount of pain, you should be having this pain control to improve your quality of life. Genetic testing is not needed because prostate cancer doesn't run in my family. That's not true because family history is almost not reliable. And I don't know, it's because back in the day, patients didn't really share with each other their cancer history, the big C word back in the day, right? But metastatic prostate cancer patients should be offered genetic testing. And there are laws that are out there in Canada as well that protect the patients, right? So if you have something on your report, insurance companies or whatever are not entitled to receive that and base any decisions based on those reports. Okay, so there are laws protecting you for that. Immunotherapy can cure my metastatic prostate cancer. I get asked about immunotherapy quite a lot. I mean, the truth is that prostate cancer is not a very immunogenic cancer, unfortunately, and unless you have a very special type of prostate cancer called MSI high disease, which is about 3% of all patients. The immunotherapy single agent in trials have shown response rate about 5% or so. So it's really not, taking up so far in prostate cancer, but there are combination studies that are ongoing to try to see if immunotherapy can be combined with something else. So I will maybe skip the last three, and then just to conclude that, overall, we are improving patients' survival with prostate cancer over time. And we see the red line here. This is one of the examples is showing the mortality of prostate cancer is decreasing in Canada, which is very encouraging. And I'll conclude the talk by saying that, if you remember anything from today's talk, that advanced prostate cancer is not just one disease. We really have to individualize the treatment for our patients. The treatment landscape is rapidly evolving and can be quite challenging to keep up. But ADT alone, for example, should no longer be recommended for the majority of patients with metastatic disease. We need to improve our real-world outcomes for patients with metastatic prostate cancer. And we need to think about how we deliver precision medicine to prostate cancer with the arrival of PARP inhibitors, testing patients and counseling patients on these mutations. The management of advanced prostate cancer is and should be a team-based approach. So gone are the days where you just see somebody for ADT injections alone, or you see a radiation oncology and then that's what you're going to see, and that's it. You're going to see different doctors along the way, and that will help you with different aspects of prostate cancer management. And we have lots of ongoing trials and research to further improve the outcomes of our patients. So really excited for those data to come and add more to our treatment armamentarium.
And on behalf of everybody, first of all, I want to thank you very, very much for such a wonderful presentation on a topic that is so interesting and so very important for all of us. And indeed, we have a lot of questions. So I am going to try to go through them so that we can And I will start from the very first one. I would like to know your opinion about the new research dealing with the inhibition of circadian proteins, as that seems to be hijackers by the prostate cancer.
I have to say, I'm not an expert on circadian rhythms. I think there is some preclinical data on this. I'm not sure how far it is in the research development, but certainly I'm not aware of any trials that are looking at this. So unfortunately, I can't really tell you a whole lot about it at this time.
Okay, thank you. I would like to know about recent evidence that testosterone replacement therapy can also be effective.
Right. So I think this question was really trying to maybe get a sense of where we're at with bipolar androgen therapy. So it is a very controversial topic. And I have to say, I've had some patients with significant side effects on ADT. Now, the vast majority of patients tolerate ADT quite well, but a select few have really debilitating side effects of ADT, which really puts us in a difficult situation because we can't really layer on a lot of our treatments without ADT. And so in that setting, I have asked, certain colleagues of mine in Canada and some in the US as well. And I can say that, and I share the same sentiment when I say this, that probably most of us in the prostate cancer community have some reservations about bipolar androgen therapy, because if the risk is that when you're giving testosterone, these cancers actually use testosterone as its food, it can really, considerably grow and cause problems like pain, fractures, whatever. So I think the other thing is that some of the research done with bipolar androgen therapy in the States have been done in very selected and controlled settings where they have protocols in place, where they have very experienced team in place monitoring the patient. And that's just not something that can be set up outside of clinical trials at this point. And certainly I'm not aware of anybody doing something like that in Canada. So if you have another option, right? And for my recent patient, we talked about potential options of, maybe using a weaker version of ADT, maybe using, I don't know, like there's some patients who can self-pay for lutetium, for example. But if you can't tolerate ADT, that is still the standard of care and we know has the best outcomes. Whether bipolar androgen therapy can even beat our standard care is not known. And certainly there are risks and shouldn't be taken lightly. So if you're going to go do something like that, you've got to go where a clinical trial is in place, where you have, very careful monitoring. And I'm afraid to say that it's not set up yet in Canada because of safety concerns.
Thank you, Dr. Jiang. Now, he has a second question, and it is about the utility of systemic treatments beyond ADT for 3B patients. He is asking why sometimes they have to wait for stage 4 and not offer these options earlier.
Right. So I think, to be honest, the patients with stage 3B cancer often are not in my hands. They're kind of in the urologist's hands or maybe radiation oncology. But I typically see patients with very clear stage 4 disease, often that need chemotherapy. But I think the challenge is that a lot of these tumors are quite extensive. And they sort of borderline between, can they consider any local therapy versus do you need systemic therapy? And local therapies can often be very challenging. And the other situation might be is that what you're seeing may be the tip of the iceberg. And sometimes the doctors need to wait a little bit to know what the trajectory of the disease is. So if you're going through like an extensive operation, for example, and your disease is going to blow up in 2 months, then again, that's not best use of that's not the best strategy when you have a lot of issues after surgery and you're not any further ahead. So sometimes, you know, getting a little bit of that sense of what the disease is doing in a tricky situation might help to decide, you know, maybe systemic therapy later on makes sense. But it's, I think it has to be really individualized. These patients usually are discussed at tumor boards. So I'm not sure what the individual sort of scenario is, but those are my initial thoughts.
Thank you, Dr. Jiang. Has a question that might apply to several of us at the meeting tonight. He had robotic surgery, and his PSA is rising, but the PET scan does not show anything. So he's asking about the next step. Is radiation logical, or what does one do when PET scan doesn't show anything, but the PSA is rising? A chemical recurrence?
Yeah, I mean, yeah, I think this is probably for the radiation oncologist, but you know, if we didn't have the PSMA PET, you know, often we would think about salvage radiation in this situation. If the disease is still localized in the area, there are some patients that they can treat and get a good outcome. It would be I would say it's probably a good thing if the PSMA PET is negative, didn't show any metastatic disease. There are some situations where you have tumors that are PSMA PET negative. Those are quite unusual for an earlier stage disease. It's different if you had multiple lines of therapy like chemotherapy. But I mean, I think that may be something to discuss with your radiation oncologist, but you know, certainly if you didn't have the PSMA PET, the standard of care would be radiation.
He asks if you could explain the ARROW trial.
Right. So the ARROW trial is another radioligand trial. It's I mean, at our center, it's actually run through urology. It's not run through one of us. But I've put 1 or 2 patients on. The ARROW trial is looking at enzalutamide in patients with castrate-resistant prostate cancer with a, I believe it's I-131. It's like a radioligand therapy with radioactive iodine, which is another sort of radioligand therapy. And similarly, you have to have a PSMA PET to demonstrate you have avid disease. And if you meet all the eligibility criteria, you can get enzalutamide plus the I-131, I think, versus enza alone after you progress on abiraterone. And similarly, in a lot of these trials, at the time of progression, if you're randomized to enza alone, you can I believe, cross over to the radioligand therapy. It is kind of competing with the SPLASH study that we have currently. I think that, you know, they're both testing radioligand PSMA targeted therapy. It's, you know, it's just the ARROW is looking at a backbone of enzalutamide, where the SPLASH has a bit more flexibility. You can do either Abi or enza depending on which pill you started with. So that's another one that's open, but it's through urology at our center.
Is asking if you could comment on ADT plus ARIT drug on MCSPC patients and the availability of ARAT on the Ontario drug line.
Right. So it's I think this question is really thinking about access. So yeah, so we're very fortunate at Princess Margaret. We have a dedicated team to look for coverage for these drugs. So when Zytiga first came, and also when the other AMIs, so to speak, the enza and the APA, when they first came, they all came with like a compassion access program, and then Abi, then the compassion access program closed and the Abi went generic. So I think there's some patients, depending on their insurance situation, and if their age is under 65, they may have difficulty accessing Abi. I think, first of all, you know, if you're having access issues, but if you're open to have other options available, like if you can't access Abi, but you can do enza and APA, those are all really great options. There's really very few absolute contraindications. If you have another option, I wouldn't think that there are any significant differences. But in our institution, working with the drug reimbursement specialists, we have been able to get most patients on one of them. So it just, depends on what your options are, and talk to your doctor about if you can't get AbbVie, maybe something else can be available to you.
Asking if you could comment a bit on the efficacy of lutetium-177 in the real world.
Yeah, great question. We're actually planning to write a review paper on lutetium-177 in the real world. So, obviously it's not yet Health Canada approved, so it's not going to be used. It hasn't been used yet in the vast majority of cases in sort of the vision sort of setting post chemo, but we have the trials of SPLASH, for example, and the ARROW, looking at lutetium in a clinical trial setting. I think so far what we're seeing is very promising. Again, I don't have any data, but the patients that I've treated on SPLASH, we have about maybe 25 to 30 patients treated. I think vast majority of patients are doing very well. I haven't seen any major toxicity. But the caveat is the SPLASH study is using a lower dose of lutetium than some of the other trials. So whether that affects things or not, we'll have to see. But most of the patients have responded. We'll see how long the response lasts. We don't know that yet. And then, like I said, in the other sort of aspects of real world adoption, the challenge, there's a couple of challenges. One is the PSMA PET access issue. Number two is what dose of lutetium really is the best. The vision therapy study and SPLASH, the three that I'm familiar with, I think the radioactive iodine in ARROW is a bit different, but anyways, for the three studies using this PSMA lutetium, they're all using different doses. The other two are using every 6 weeks, SPLASH is using every 8 weeks. So we don't know what is the optimal number of cycles. Like SPLASH is doing 4 cycles, the other two is doing up to 6 cycles. And there's a lot of unanswered questions about also like what is the positive threshold for PSMA PET positivity? How do we follow these patients? Do we need PSMA PET to follow these patients? Probably not, but like, how do we think about imaging these patients after PSMA PET? When do we do the PSMA PET? We have some data that if you just start on ADT, for example, you probably shouldn't get a PSMA PET right away because it may affect the positivity detection. So a lot of these issues may need to be ironed out in the real world. And so it's going to be a learning curve and some hurdles to jump through initially, I'm sure.
I had a question early during your presentation about the psychological impacts of the use of all these different treatments. You addressed it a bit later on. He agrees that you did, but I don't know if you want to add anything. Do you recommend, for example, speaking to a psychologist or psychiatrist during treatment? And how does one go about that?
Yeah, it's a great question. I think we're all learning about how to really even talk about some of these issues. I think the first is just to be aware that these things can happen and you're probably not alone, right? So there probably is a lot of patients who are in the same shoes and trying to figure out what's going on. And what to do, and what happens if I speak of what else is out there, and all of these questions. But I think the first thing is to just sort of figure out how are you feeling? Are you feeling that you're losing interest? Are you feeling you have a really low mood and you're not enjoying the things that you used to do? And if you have any of those two things, I would say talk to your doctor, and sometimes your doctor has limited time, but you want to make sure that you bring up this issue. And not just, the same sort of, are you doing okay on treatment? But, you really want to talk to your doctor about this because it is important. And you also have to recognize that your doctors don't know everything about, how to evaluate psychological impacts. So you really have to work together to really figure things out. But, the approach that I have is somebody tells me that, I try to get a baseline assessment of what is the severity of how this is impacting the patient. There can be anywhere from the patient is having suicidal ideation to, they're actually coping okay, and it's just sort of intermittent adjustment to the diagnosis type of thing, right? And anywhere in between, right? And these things can change over time as well. So it really depends on how severe it is. Then we may have to think about the urgency of the situation. But in our Princess Margaret environment, our psychosocial department actually makes it very easy for us. So you first get connected to an intake person essentially, and they get a baseline assessment, and they are trained to do this, unlike us, right? And they're trained to do this. And if, let's say, you need to see a psychiatrist for medications for these type of things, then they can direct you. If you just need some coping strategies, and there's everything from, counseling to even music therapy, art therapy, then they can connect you to that. If you need to see a psychologist, they can connect you to that. But I think it's recognizing that first you have to bring up the issue to your doctor, because we're not the best at assessing these things, unfortunately, because we're only seeing you for a short period of time, and you have the most time with yourself or your caregivers, your family members. So make sure that if this is something that's affecting you, you come talk to us, and I'm sure that there are resources available, and don't be afraid to use them.
And he would like to know what led you to choose prostate cancer as one of your specialties.
Okay. Thank you, Erwin, for that question. So, I think that probably like a lot of things in life, it's many things. Where do we even begin? Well, I wanted to become a medical oncologist initially because I did have, cancer affecting my family. And my grandfather actually died of metastatic prostate cancer. And of course, he didn't have all the treatments available to him. He didn't have any of these sort of targeted agents available to him, and he had a lot of bone disease, so it was quite painful for him. But I think it's a number of things between sort of the personal connection with men with prostate cancer, and also just the amount of research that has really taken off, right? So like I showed you some of the timelines, there's a lot of new things happening, which makes it really exciting that by joining the prostate cancer community, I can make a difference and really help to propel this movement forward. I still have to figure out how to contribute to prostate cancer, for example, at times like Movember, because I don't have a mustache. I hopefully will never grow a real one. But, and I think there is not as many women in prostate cancer either. And I think it, helps to have that different perspective and hopefully make a difference.
Is asking about ADT that castrates you, so there is no testosterone and therefore no estradiol. And he wants to know why we don't use transdermal estradiol to return men to the normal range of estradiol.
Estradiol, yeah, great question. Yeah, I think we need more data. I think that estradiol has, it's probably very important in the bone, in bone health. I guess it's just how do we best incorporate estradiol in patients who are getting things like ADT when they're having castrate levels of testosterone. One of the things that estradiol can induce is there's a thrombotic risk. The transdermal is probably way less risk than the oral options for the female hormones. But when you have an imbalance of female hormone versus male hormone, that's when you can get into certain side effects. And how much do we need to get the benefit of, strengthening your bone? In the context of we already having, like us already having, fairly, good underutilized strategies for bone health, like calcium and vitamin D, there's I think, way under usage of these things. Bisphosphonates, again, even when we look at the vision trial, which is recent, right? That was just reported last year. I think something around like 30 to 50% of patients are getting a bone targeted agent when everybody in the MCRPC setting should be getting one. And, I have no doubt that there's room to improve, but I think, how does estradiol fit into that situation? How do we also improve the use of these agents, which are very well tolerated and has really proven benefit in this specific prostate cancer situation?
They would like to know if sugar intake would cause cancer to increase.
Yeah, this is a very common question, and there's no evidence that sugar intake affects the cancer growth in any way. So sugar is a I'll say carbohydrates is a necessary nutritional food group for us. You cannot completely eliminate carbohydrates, or your body cannot function. Right. So for example, your brain, when it's working, it only uses carbohydrates. I think it's glucose, but it only uses carbohydrates to function. So our bodies are not designed to completely eliminate the intake of sugar. Now, if you decrease the amount of sugar, if you've been an excessive sugar eater before, there has been many benefits, reducing risk of diabetes and things like that. But in terms of prostate cancer risk, I think it's probably fairly negligible. The cancer is growing because the prostate cancer has probably developed some sort of changes in its DNA to bypass a lot of our natural defense mechanisms to keep the cancer cells in check. And, having some sugar in the system, unfortunately, is not going to change those complicated pathways. So you want to make sure, if you're doing it for the reasons of your general health, that's great, but you don't want to overdo it that you get sick or something like that. But for prostate cancer, there's not a whole lot of evidence it can change the trajectory.
Is interested in knowing how he could get into some of your trials. Does he talk to his oncologist or to his urologist?
Yeah, it's a great question. And thank you for thinking about trials. I think the one thing to know is that there are so many trials ongoing. And some are going through urologists, some are going through radiation oncologists, and some are going through us like medical oncologists. There's just no way we can remember everything in everybody's specialty when it comes to clinical trials. I think sometimes just asking your doctor to say, hey, are there any clinical trials available for my situation? And typically there's a big team behind the scenes, right, that can screen you for trials. Depending on your situation, if you're under the hands of a urologist, and if you have metastatic prostate cancer, just maybe hinting them, is there anything under radiation oncology or medical oncology? Is a great start. For us, for the medical oncology side of things, almost all of our trials are in the metastatic space. So if you're not under the care of an oncologist, the urologist can refer you if you might be eligible. We can happy to see you and assess you. And if a clinical trial is appropriate and could be beneficial to you, then you are under the care of both us and your urologist, just depending on your situation.
Has a question that actually would apply to several other people as well. And he has a localized tumor where the prostate was, I guess he means his prostate bed. And he's on enzalutamide and Zoladex, and his PSA is rising. So he wonders if radiation would be helpful, if he could have radiation.
Right. That's it's a bit of a tricky question because it's you need a lot more information on that scenario. So if, let's say, your PSA is like 100, for example, you probably radiation is not going to help, and if it's doubling really quickly. So it depends on the trajectory and the extent and things like that. But they also, I'm not a radiation oncologist, but there are certain situations where radiation is not possible. So let's say if it's a localized tumor, but it's really near the bowel or something, and you're just not able to give the radiation safely to that area, then unfortunately systemic therapy might be the way to go. If, let's say, there's localized disease, but there is too extent of a disease that it's cannot be encompassed in one radiation field, or whatever they say, like it's just too big for the radiation oncologist to map out, then it's not amenable, then you have to have systemic therapy. If, let's say, somebody had a history of prior radiation because they had a rectal cancer or something, or they had prior issues in their pelvis, like, or in their bowels, like somebody has inflammatory bowel disorder that they can't radiate safely, like all of those situations might play into a role in that decision making. So it can be very complex depending on the situation.
I would like to know if calcium supplements contribute to heart disease.
That's a great question. I'm not an expert on calcium supplement heart disease. I think that you have to probably assess that by the other doctors who's more familiar with heart disease. But I think it's always a benefit versus risk, right? So in terms of heart disease, usually the biggest risk factors for heart disease is not your calcium supplements. It's, you know, your high blood pressure, your diabetes, family history, so on and so forth. And we also know that in the setting of prostate cancer on hormone therapy, osteoporosis, fractures, hypercalcemia, like changes in calcium levels, and requirement for radiation surgery even to the bones because of significant pain, like all of these things are very real for prostate cancer patients, for on the bone side of things. The other thing, there's increasing data may be suggesting that calcium, vitamin D may play a role in sort of cognitive health as well, and similar to exercise, that type of thing. And so people who are, like, for example, like vitamin D deficient or something, there is some literature saying that these patients can have impact on their cognitive abilities, which is also a very real situation for prostate cancer patients. So I think in my mind, if you're on ADT, if you have extensive, if you have bone disease, and especially if you've been on treatment for a while, the risks of these things in the prostate cancer setting may be considerable. And I think getting calcium supplements is important. And also, outside of prostate cancer, I can tell you that the vast majority of Canadians are calcium deficient in a way, because we're just, you know, and probably me included, we don't get a lot of sun exposure throughout the year. We also are doing less and less activity, unfortunately. And, you know, for me, I'm not a huge milk drinker or dairy consumer. So the amount of calcium that I ingest in my diet is probably nowhere near enough than the sort of 800 to 2000 sometimes that they recommend. So I think for the most cases, I would say the calcium supplements are actually quite important.
Okay, Dr. Jiang, that was the last question. Dr. Jiang, I want to thank you very much on behalf of everybody that came to this presentation. As our appreciation to you for your participation tonight, Dr. Jiang, Prostate Cancer Support Toronto will make a donation on your behalf to the charity that was of your choice. So
thank you.
Before I go to some of the details of how this video will be presented later, I want everybody to join me in a big applause to Dr. Jiang as our thanks. Thank you very much.
Thank you, everyone. Thank you so much for your attention, for your questions. You guys asked great questions, and thanks for sticking to the end.